Good evening, everyone. Welcome all to BOA PG teaching program. As you know, the initiative that we started in lockdown and we have continued till today in the fourth season of the BOA. Basically, we are focusing on all the foundation topics of the ophthalmology. And one of very important question in your exams and even in your clinics is diabetic retinopathy management. We have done one lecture on diabetic retinopathy, and now we are focusing main towards the medical and the surgical management of the same. And to teach us, we have none other than Dr. Bibhuti Kashyap sir with us. He has done his residency and his refractive and his retina SRship from the AIMS from Rajendra Prasad Eye Institute, and at present he is working in the Kashyap Eye Institute in Jharkhand, and sir will be talking about diabetic retinopathy management. Over to you, Bibhuti sir, and thank you for accepting our invitation.
The pleasure is all mine, Dr. Smith, and good evening, everyone. I'm Dr. Bibhuti Kashyap, and if you allow me to just share my screen now. So I will be talking on first the medical management of diabetic retinopathy, and then we'll be going on to the surgical management. Am I audible and visible?
Yes, you are audible and visible. You can make it full screen, sir, now.
All right. All right, so starting up with the medical management of diabetic retinopathy. So the first step towards managing a diabetic retinopathy or a diabetic patient is to know when do we screen them. So the first examination in a type 1 diabetes mellitus should be 5 years within 5 years of the diagnosis, and the type 2 diabetes mellitus at the time of diagnosis of diabetes mellitus. If there is no retinopathy visible, yearly screening should be done as a follow-up. If the patient is having a mild to moderate NPDR, the follow-up should be 6 to 12 months. And if it's a severe NPDR, 2 to 4 months. If the patient is having a diabetic macular edema, the follow-up should be at 2 to 4 months. If the patient is pregnant, so if we know about the diabetic history prior to conception, this should be done before conception. And if it's a gestational diabetes mellitus, we should start the screening early on in the pregnancy, in the first trimester. If there is no retinopathy, or if there is a mild to moderate retinopathy, we can repeat the follow-ups at 3 months. And if it's a severe NPDR or a PDR, a follow-up should be monthly. That's what you should remember. Treatment options, medical treatment options for a diabetic retinopathy is first comes the systemic control. Second is the laser therapy, and then of course the pharmacotherapy in the form of anti-VEGFs and steroids. So how does systemic control help us? Various studies HbA1c levels of 7 to 7.9. Although American Diabetic Association recommends a glycemic control targeting HbA1c of 7 or less than 7. With respect to hypertension, the UK PDS study shows that a tight blood pressure control of less than 150 systolic in type 2 diabetics has been seen to reduce progression of DR by 34%. And the ACCORD study, it showed that a very aggressive and very tight control of blood pressure with systolic less than 120 when compared to 140 did not show benefit in reducing the risk of retinopathy. So less than 150 is fine, less than 120 is not really required. With respect to lipid levels, the field study of the fenofibrate intervention in event lowering in diabetes, it concluded that fenofibrate reduced the frequency of laser requirement in DME. And in ACCORD study, the intensive control with combining of fenofibrate with simvastatin did not have long-term persistent effects. So consistent results related to the effect of lipids have not been found. Now coming to the most commonly used modality for treatment of retinopathy, that is laser therapy. How does lasers work? Basically, it destroys the outer retina and RP in the conventional laser, of course, thereby increasing the oxygen supply to the inner retina. And it decreases the production of VEGF and thereby causing autoregulatory vasoconstriction, reducing in vascular leakage. So this is an example of a focal laser being done, where laser to focal leaks, which are very discrete and solitary, are done to reduce the leakage from those leaky capillaries. They are direct laser to leaking macroaneurysms in area between 500 to 3000 microns from center of macula. For a diffuse thickening or a diffuse leak, we do a grid laser to all areas of retinal thickening or area of diffuse leakage on angiography between 500 to 3000 microns from the center of the macula. Now, coming to the specifics of the macular laser, in the direct or the focal treatment, the microaneurysms are lasered, which are present 500 to 3000 microns from the foveal center. In the grid treatment, the area from 500 to 3000 microns superior to the macula, nasal to the macula, and inferior to the center of the macula is lasered, and temporally 500 to 3500 microns are lasered, and no burns are placed within 500 microns of the disc. The spot size of these burns are 50 microns. In the original ETDRS technique, it was mentioned to be of the value of 50 to 100 microns. The duration for these burns should be 0.05 to 0.1 seconds. They should be mild gray-white burn, and the spacing should be at least 2 burn width apart. The wavelength used is a 532 micron Nd:YAG laser or argon green laser under topical anesthesia. So this is an example of a grid laser being done. To your left hand side is the clinical picture of the grid laser. Because it's a mild gray-white burn, it's not easily discernible. But if we do the angiography, we can see a C-shaped pattern of grid laser marks around the macula. Here, the papillomacular bundle over here is spared of the laser spots. Now, there are two techniques of doing a grid laser. One is a modified ETDRS technique and one is a mild macular grid. The basic difference in between these two grid laser patterns are that in the modified ETDRS technique, the laser burn is applied to the areas of diffuse leakage, non-perfusion, and it involves a direct treatment. Whereas in a mild macular grid, it is distributed, the burn is distributed throughout the macula in both areas of thickened as well as unthickened retina. Now, in a study that compared the two, it was found that a mild macular grid is less effective than a modified ETDRS. So we follow the modified ETDRS pattern of grading, grid laser. This is an example of a proliferative diabetic retinopathy without HRC. The black arrows show massive neovascular proliferations. These are the large NVEs, but because they're not having associated bleed, it still does not fall into the HRC or the high risk criteria. This is an example of a PDR with HRC where we can see a massive bleed in the fundus picture, and to your right is the angiography picture of the same patient. So for these PDR patients, the standard treatment is a PANRETINAL photocoagulation. Now, coming to the specifics of them, in a single spot laser, we do a moderate burn, duration of 100 milliseconds, spot size of 500 microns, and spacing is a 1 burn width apart. The extent, what is the extent? The extent is from major arcades posteriorly to at least the equator anteriorly, or as anterior as possible, not closer than 500 microns to disc nasally, and 3000 microns from center of macula temporally. It can be done with the use of a slit lamp delivery or LIO machine, or the laser indirect ophthalmoscopy machine. The burn should have an immediate gray-white mark. There should be 1200 to 1600 burns delivered over 2 to 3 sessions with the use of the same laser that is used for the grid. So this is an example of a PRP done using a single spot. To your left is a complete PRP's clinical picture, and to your right is the angiography of the same patient. This is the image used taking an ultra wide field system. Coming to multi-spot or pattern scan laser system, or PASCAL, it basically delivers multiple spots in a single pedal press. So it allows for a quicker laser delivery of pan-retinal photocoagulation. So it uses a microprocessor-driven scanner which provides with a variety of scalable patterns. Multiple spots can be applied. Pulse duration is usually 20 milliseconds, and 1800 to 2400 burns can be applied in a single session. This is the PASCAL machine and the patterns available. You can see a uniform pattern of photocoagulation can be achieved in a lesser time with PASCAL. Now, other modalities of laser which the postgraduates may or may not be doing, it's not readily available at all the centers, and it's not of much practical importance, but I thought of discussing it here, is the micropulse laser therapy, where the laser application is at sub-threshold levels in the form of micropulses, which is shorter than the thermal relaxation time of RP cells. So there is selective damage to the RP, and the photoreceptors and choriocapillaries are spared. And there are no visible laser burns immediately or scars in the long run. So it reduces the visual field damage that happens with the conventional laser. And the laser used over here is the infrared diode laser of 810 nanometers wavelength, or the yellow laser of 577 nanometers. There is something called as SRT, or the selective retina therapy, where a frequency doubled neodymium yttrium lithium fluoride ND-VEGF 527 nanometer laser is used. So what SRT does is it does not damage the RP cells. Just previous to this, we saw how micropulse laser therapy damages only the RP cells and not the photoreceptors. This one preserves the RP also. It instead, the laser is instead absorbed by the melanosomes, causing a thermomechanical disruption with a microbubble formation, causing a migration and proliferation of RP cells. So if used in the areas of vascular leakage, this seals the leaking retinal barrier, and adjacent photoreceptors and choriocapillaries are not affected. So do these lasers have a side effect? Of course, it is a slightly painful procedure. If we do laser to the raised in the presence of a raised fibrovascular proliferation, then there is conversion of these fibrovascular proliferations into a prominent fibrotic proliferations, and that causes contraction and a resultant vitreous hemorrhage or detachment. It decreases the contrast and color vision, accommodation problems, constriction of visual field. You may burn the macula accidentally. We may have a secondary CNVM or exacerbation of macular edema if extensive PRP is done, especially in presence of diabetic macular edema. Coming to pharmacotherapy in the form of anti-VEGF, what is the mechanism of these anti-VEGFs that we usually see in the market? So in diabetes, VEGF is upregulated due to microangiopathy associated ischemia. So that VEGF increases the retinal vascular permeability and it causes the breakdown of blood retinal barrier, resulting in macular edema. So anti-VEGF agents directly act on the VEGF molecules and reverses or stops this pathology. So the main anti-VEGF drugs used in diabetic retinopathy are Bevacizumab, Ranibizumab, or Aflibercept. Bevacizumab is a humanized IgG monoclonal antibody. Ranibizumab is a smaller molecule, is just a Fab fragment of humanized IgG monoclonal antibody. And Aflibercept or VEGF trap is basically a decoy receptor where VEGF-R1 and VEGF-R2 both are antagonized with Aflibercept, and it also acts against the placental growth factor. So it's a stronger molecule with a longer duration of action, roughly saying. The dosage of Bevacizumab, Ranibizumab, and Aflibercept. Bevacizumab is 1.25 milligrams per 0.05 ml. Ranibizumab is 0.5 mg per 0.05 ml, and Aflibercept is 2 milligrams in 0.05 ml. So basically, the dose of anti-VEGF is 0.05 ml. This is an example of a diabetic macular edema. To your left is the pre-injection picture of OCT of a patient with diabetic macular edema. We can see some cystic spaces at the fovea, and to your right is the picture of the same patient after one injection of ranibizumab. This again is an image of a very large cystic spaces in a patient of a severe DME, which was treated with a combination of anti-VEGF with steroid, and the contour of the macula was restored after 2 injections. And the post-op is to your right. So what are the anti-VEGF regimes that we know of? What is the way in which we tend to space out these injections? So one is a fixed regime, one is a treat and extend regime, and one is a pro-re-nata regime. A fixed regime are fixed monthly injections irrespective of the OCT findings on follow-up. A treat and extend regime is monthly injections until maximum clinical response is achieved, followed by increase in the interval depending upon the disease activity. And a pro-renata or a PRN regime is as and when you require it, depending upon the OCT and the clinical features. So do we have some studies supporting it? So DRCR net has a huge database of various types of studies. It has various protocols, either published or under investigation. So a protocol I of the DRCR net that analyzed basically the efficacy of intravitreal anti-VEGF ranibizumab as compared to triamcinolone. So the 4 arms were sham plus prompt laser, ranibizumab plus prompt laser, ranibizumab plus deferred laser, or tricot or triamcinolone plus prompt laser. So the expanded 5-year results of protocol I demonstrated that the mean difference in BCVA change from baseline was lesser in the ranibizumab plus prompt laser treatment group compared to ranibizumab plus deferred laser. And in pseudophakic eyes, intravitreal triamcinolone with prompt laser may be equally effective as ranibizumab at improving the visual acuity and reducing retinal thickening, but with the risk, of course, of rise in the intraocular pressure that happens with steroid use. RISE-RIDE are the 2 studies that were undertaken to get the FDA approval for ranibizumab use in diabetic macular edema. And these studies, of course, showed that ranibizumab was effective in resolving the edema. Then comes the READ-2 trial. Here, there were 3 groups which were compared for treatment of diabetic macular edema. There was ranibizumab, laser, and ranibizumab plus laser. So, it showed that basically long-term improvement in visual acuity could be maintained with ranibizumab monotherapy alone. But 3 years extension of the READ-2 study, revealed that if we do a monthly follow-up and aggressive retreatment with ranibizumab, then a central subfield thickness reduction can be maintained even without the laser therapy. Then there was a study, Restore and Reveal. This compared a 0.5 milligram ranibizumab with laser with ranibizumab plus laser. The 3-year extension of the Restore study showed that ranibizumab was effective in improving the BCVA and CST outcomes with declining number of injections over 3 years using a PRN approach. Coming to bevacizumab, again, bevacizumab is always an off-label use because it has not been FDA approved, but DRCR net protocol H evaluated the effect of bevacizumab and laser. So compared to the laser arm, patients receiving the bevacizumab injections had a greater reduction in central subfoveal thickness at 3 weeks, and no difference was noted between the 2 doses. BOLD study was another study that was evaluating bevacizumab. This was the bevacizumab or laser therapy. It showed that greater treatment effect than modified ETDRS in patients with persistent central involving CSME. It also supported the long-term use of bevacizumab. So if ranibizumab or bevacizumab both can be used as monotherapy if the edema is mild. Coming to Aflibercept, the studies evaluating Aflibercept were the Da Vinci study and the Vista and the Vivid study. Da Vinci study, of course, showed that Aflibercept showed significant improvement as compared to laser in diabetic macular edema, and Vivid and Vista studies showed that the efficacy was similar in both the treatment regimes. Monthly regime of Aflibercept versus 2 monthly regime of Aflibercept. So Aflibercept has reduced frequency of injections and has a similar outcome. There was a DRCR protocol T that compared bevacizumab, ranibizumab, and Aflibercept. This protocol suggested that all of these are equally effective therapy for central involving DME with no difference in adverse effects. And Aflibercept superiority to ranibizumab at 1 year was no longer present in the 2-year results. So, and eyes with baseline visual acuity of 20/50 or worse has less vision improvement with bevacizumab. So basically what it meant was that bevacizumab, ranibizumab, and Aflibercept all can resolve diabetic macular edema. Ranibizumab and Aflibercept are not different. but both of them are significantly superior to your Bevacizumab. Coming to steroids, steroids are used usually in cases of refractory or severe DME, because anti-VEGF therapy may not be effective in very severe DME. The IVTA is usually not preferred due to high incidence of increase in IOP, so one can always use Ozurdex. Ozurdex is a dexamethasone implant which has 0.7 milligrams of dexamethasone. So again, coming to the Bevordex study, it showed that there were similar rates of BCVA improvement. Although, of course, you had when there is an implant, you have more chances of developing a cataract. But here the steroid was inferior. But of course, steroid has to be used when there is a severe refractory DME. So either in isolation or in conjunction with anti-VEGFs in single or multiple doses spaced 1 month apart. The DRCR protocol U, it evaluated the role of steroid in persistent DME. So this comparison was with anti-VEGF plus Ozurdex versus anti-VEGF alone, and the average gain of visual acuity at 6 months was same, but the improvement in the retinal thickening was, and that is the thing that we look for in the OCT, was greater in the combination of steroid and anti-VEGF group. So when there is no diabetic retinopathy, we just need to do a regular clinical examination with indirect ophthalmoscopy of a diabetic patient. The routine investigations of angiography, OCT, and a clinical picture is not required, and the follow-up needed is annual. In a case of mild to moderate NPDR, a fundus color photography is used to document, because the diabetes, the DR has set in. The OCT has to be done to document the macular edema, which is not clinically that apparent. Mild to moderate NPDR alone per se does not require treatment and can be followed up 6 monthly. But if it is associated with your diabetic macular edema, or if it is, or if on angiography there are leaking microaneurysms and large CNP areas, especially in a fellow eye in which the other eye has been severely damaged because of a PDR, or the patient is having a high risk factors, we may go ahead with targeted laser photocoagulation of those capillary non-perfusion areas. In case of diabetic macular edema, in these mild to moderate NPDR cases, if the DME is center involving, the follow-up has to be every 4 to 6 weeks, and if it's non-center involving, it can be every 3 months. This is the treatment algorithm for DME in a case of mild to moderate NPDR. It is just a tabulated form of what I just said. If, of course, there is a mechanical traction to the macula, we may go ahead with a vitrectomy in refractory cases. But usually in a case of mild to moderate NPDR, the DME usually is not very severe. If it's not severe, just go ahead with anti-VEGF. If it is severe enough, we may have to go in with a combination of anti-VEGF and steroid. The DRCN protocol V, this was, this addressed the best therapeutic strategy for eyes with center involving DME and good vision. So what to do if there is edema in the OCT and but the vision is very good. So it compared intravitreal Aflibercept versus macular laser versus observation. So at 2 years, the rates of vision loss were similar in all 3 groups. So basically the conclusion was that observation can also be a non-inferior and reasonable initial strategy for treatment naive eyes with good vision despite a center involving DME. So this according to me was a very good study that substantiated the role of, substantiated the avoidance of overuse of anti-VEGFs in whatever thickening we see on OCT despite good vision. Coming to severe, very severe and non-high risk PDR, a severe NPDR, of course, is the one with more than 20, either one of more than 20 intraretinal hemorrhages, definite venous bleeding, or a prominent intraretinal microvascular anomalies in at least one quadrant. A very severe NPDR is an NPDR with more than or equal to two of the above features. High risk PDR, as defined by DRS study, is moderate or severe new vessels within 1 disc diameter of the optic disc, mild new vessels on or within 1 disc diameter of the disc if fresh vitreous or pre-retinal hemorrhage is present, or NVE if fresh vitreous or pre-retinal hemorrhage is present and if the area of new vessels was half the disc area or more. So in such cases, of course, the fundus color photography and OCT has to be done at each follow-up, and the follow-up has to be within 2 to 4 months. In doubtful cases of severe and very severe NPDR, angiography may be done to identify the new vessels, because in what looks clinically like a severe or a very severe NPDR can also turn out to be an occult PDR with very fine vessels, which may be missed with naked eye. So over there, we may need to start a PRP as early as possible, but we tend to look at only the macula, considering it's just a severe NPDR. It may not be requiring laser. So an angiography, I would say an angiography should be included in every case, severe NPDR onwards. Now, in these cases, a pan-retinal full scatter photocoagulation can be considered. Even, till in ETDRS study, it was said that it may be considered in very severe NPDR or in PDR with HRC. But nowadays, even in severe NPDR or a very severe NPDR also, a PRP can be considered, where a regular follow-up is doubtful, healthcare access is limited, a patient is a patient of type 2 diabetes, in cases where the fellow eye is lost to diabetic retinopathy, or if there is an impending cataract surgery or pregnancy. If the diabetic macular edema is also present, as I discussed earlier, if there is a macular edema, we need to address the macular edema first, because doing a PRP further can exacerbate the macular edema. So if there is a severe form of diabetic retinopathy with a macular edema, treat the macular edema first, inject the patient, and then go for the PRP so that it negates the exacerbation of DME in such cases. I'd love to discuss the DRCRN protocol S. This was prompt PRP versus Ranibizumab and deferred PRP in PDR. So the use of Ranibizumab and deferred PDR is a reasonable alternative. The mean change in visual acuity in both the groups, that is, the group 1 was a prompt PRP versus the group 2 of deferred PRP with use of Ranibizumab, the visual acuity change was similar at the end of 2 years. And of course, because we're not doing laser, there is lesser peripheral field loss. Of course, need for fewer vitrectomies, lower incidence of DME. But yes, because injections are costly, and we need to monitor those patients for reversal or for reversal of ischemia in these retinas. So we need to have increased number of visits, maybe repeated injections, so increased cost of medical care. In a high risk PDR, as I defined, there has to be immediate PRP to reduce the risk of severe vision loss. Angiography is done to identify the leakage points, assess macular ischemia, and guide the treatment for macular edema. Again, even in these cases, if macular edema is also present, there has to be a combined treatment, and anti-VEGF should be given prior to the PRP, but PRP should not be very much delayed. If the macular edema is refractory, consider targeted laser to the of peripheral skip areas. If there is NVI or NVG present, a prompt PRP should be done along with anti-VEGF agents. Now, NVI and NVG is a tricky situation where we may have hazy media, we may have opaque media. So treating a PDR in the presence of NVI and NVG is a whole different topic. But if we want to cover it broadly, what we can say is, if the media is clear, go for immediate immediate and a tight and extensive PRP to reduce the VEGF load. If the pupil is not expanding, we may try for intracameral anti-VEGF or intravitreal anti-VEGF or both. Once we do that, a very prompt regression is seen in the NVI. The pupil starts dilating a bit, and then maybe we can go ahead with the complete PRP. But even in these cases, we need to have a regular follow-up, because these NVIs may regress if we have skip areas, and we may ultimately need to go for a intracameral anti-VEGF followed by TRAB or a valve surgery. This was the medical part of diabetic retinopathy. Now, I'll switch on to the surgical management of diabetic retinopathy.
Will
Now, yes, uh, should I stop, Dr. Suman?
no, 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 continue. Please continue.
All right. Okay. Is the slide visible?
Yes, yes, very much. Indications for surgery.
Okay. So now, what happens when all of those treatments fail? Like, if there is an NPDR with a refractory DME which has not resolved with injections, and we are seeing certain anatomical abnormalities in the OCT, or there is a non-resolving vitreous hemorrhage that we have been waiting to get it cleared off, or there is a fresh vitreous hemorrhage, that has happened after we have started a PRP. I mean, there are so many ways in which a medical treatment can be halted midway, or there's so many ways in which a medical treatment will not be affected due to a lot of anatomical factors. So in those cases, of course, the last option is surgery. So what are the indications for surgery in a diabetic retinopathy? So media opacities are the most common. That is a non-clearing hemorrhage. That hemorrhage can be either a vitreous hemorrhage, a subhyaloid hemorrhage, a premacular hemorrhage, a tractional component that is causing a tractional retinal detachment, which may be threatening or involving the macula. There may be a vitreomacular traction, which may be causing a hindrance in the resolution of the edema. The lesser common indications are ghost cell glaucoma, or a very problematic complication, that is anterior hyaloid fibrovascular proliferation. So coming at it one by one, so vitreous hemorrhage, the old recommendation for clearing of a vitreous hemorrhage was 3 months for insulin dependence diabetes mellitus and 6 months for NIDDM. But the current recommendation is that we don't wait for more than 1 month despite the type of diabetes. Also, DRVS showed that early vitrectomy is the norm in type 1 diabetes. So what are the surgical goals that we are looking at if the patient is having a vitreous hemorrhage? So basically, to provide a clear media, excision of the posterior hyaloid, removal of the ERM or the epiretinal membrane to relieve any kind of traction on the macula, and to, of course, progress with go ahead with the endolaser photocoagulation and complete the PRP if it has been left midway, or start and complete the PRP during the surgery. And because that, of course, converts the ischemic retina to the anoxic retina. A premacular hemorrhage should be surgically removed within 1 month because it causes extensive fibrovascular membrane formation requiring subsequent peeling, and delayed surgery leads to persistent macular distortion post-surgery. So premacular hemorrhage should be operated within 1 month. This is an example of a massive subhyaloid hemorrhage. Now, tractional retinal detachment. Some literatures say that it currently, including Ryan, for retina, that used to be our Bible. So it says that currently tractional retinal detachment is the most common indication for performing diabetic vitrectomies. So there are two types of TRDs which need to be operated, or which are dangerous. A TRD which is peripheral can still be observed, but if a TRD is threatening or involving macula, that needs to be operated. Now, what is a TRD that threatens the macula? A TRD threatening a macula are just the tractions that are causing striae at the macula or at the arcades. But a TRD involving macula is the one which is at least 4 disc diameters, with a part of it within 30 degrees from the center, or less than 4 disc diameters, but with adhesions within 30 degrees from the center. These TRDs, they progress to severe visual loss, 15% and 23% at 1 and 2 years respectively. Extramacular detachments can be observed, although some surgeons prefer to remove that also. But if it is well and truly secured with laser, it can also be observed. But TRD involving or threatening the macula, those definitely need to be removed. Vitrectomy relieves the traction by excising the tractional elements, that is the posterior hyaloid and the proliferation of the proliferating fibrovascular membrane. So what are the favorable prognostic factors in such cases? So if if the TRD is of a shorter duration, less than 30 days, if the extent is pretty limited, if there is a presence of pre-op PRP. Why? Because if there is a pre-op PRP present, the fibrovascular component tends to become more fibrotic than being more vascular. So when we are operating, it gives a relatively bloodless field during surgery. Else, it's going to be a very messy surgery where the visualization of the retina will be very difficult. So presence of presence of a PRP, a pre-op PRP always helps. Absence of vitreous hemorrhage, as I said, of course, it's a favorable prognostic factor, and of course, absence of severe neovascularization. This is a case of a very severe TRD involving the macula. So we can see the massive fibrovascular proliferation over the disc, pulling up the retina and the macula in the presence of a PRP, pre-op PRP. Now, a severe fibrovascular proliferation are the causative factors for a TRD. So what is a severe fibrovascular proliferation? A severe fibrovascular proliferation is a 4 disc diameter vascular proliferation with 2 disc diameter if at disc, or 4 disc diameter if elsewhere, fibrous component. So a 4 disc diameter vascular component has to be there with either 2 or 4 disc diameters of fibrous components associated with a pre-retinal or vitreous hemorrhage. So this basically happens in young patients. You have a very severe fibrovascular proliferation, especially in young patients with a type 1 diabetes. So, and of course, these they contract and cause a vitreous hemorrhage, macular distortion, and retinal detachment. So a conventional management is observation followed by photocoagulation and vitrectomy in presence of TRD, or in presence of a 6 month of non-resolving vitreous hemorrhage. But in current scenario, if there is a fibrovascular proliferation, if it has not caused a detachment, we do an aggressive PRP with a close follow-up to see if the conversion of that fibrovascular proliferation into a fibrous component is not causing a severe TRD, and if it does, and if it elevates the macula, or if it threatens the macula, you go ahead with the surgery. This is an example of a fibrovascular proliferation with limited tractional element. I mean, it is obviously causing a traction, but the detachment is pretty limited as compared to the previous picture I showed. A TRD with an RRD. Now, what is this? So basically, a tractional component is where we have a pull. Now, when the retina is pulled with a fibrovascular proliferation, the pull is sometimes so tight that a break is usually caused at the base of the traction. Like, if that break is usually not visible but can be sometimes visible. Why? Because it is usually underlying that proliferation. But the configuration of a combined detachment is such that we diagnose these cases with the help of clinical configuration of the detachments. So these usually requires prompt vitrectomy regardless of macular status, because once there is an RRD, it is going to progressively involve the macula. Of course, favorable factors are visual acuity of more than 5 by 200, RD not involving the macula, and absence of NVI. So here we see this is an example of a combined detachment where we can see the area where I'm pointing the cursor. This is the element of traction that has caused a secondary break at the base. So this usually is not visible, but this picture I was able to take from the internet to show how the break is present at the base of the tractional element. So as we can see, the configuration of a rhegmatogenous RD is quite different from a tractional RD. A tractional RD will have usually tenting up of the retina or a pulling up of the retina. Whereas in a rhegmatogenous RD, the retina is basically with a convex surface freely undulating. So if we see a tractional component but a rhegmatogenous configuration of RD, then that is a case of a combined detachment. So that is how we usually diagnose, because most of the times the break is not visible. Now, recalcitrant diabetic macular edema is another indication for surgery. What do we do in this? We basically do a vitrectomy with an internal limiting membrane peeling. So what is the rationale? So the vitreous detachment relieves the vitreous traction at the fovea. It reduces the cytokines from the vitreous cavity because we remove all the vitreous. It increases the oxygen permeability and increases anti-VEGF penetration. This is an example of a VNT empty, and a thick taut posterior hyaloid, which causes an edema which cannot be resolved with injections if it is not causing a posterior vitreous detachment. We have to go in and mechanically induce that. Rubeosis iridis. This is an end stage disease, and PPV has a very limited role, because even after PPV, the visual function returns, and results in the term of functional outcome is not very good. The preoperative treatment with intracameral and intravitreal anti-VEGF is a must, so that it allows for pupil dilatation. We must include a tight PRP during the vitrectomy. Ghost cell glaucoma is a relatively rare indication. It typically occurs in aphakic eyes, and vitrectomy is performed in refractory cases. Vitreopapillary traction is a sparsely studied indication. So what happens basically is that there is a traction at the optic nerve head, causing impedance in the axonic blood. The axons of the optic nerve. There is impedance of the axoplasmic flow, so thereby damaging the optic nerve. So a vitrectomy is done to relieve this traction. This is an example of a vitreopapillary traction. You see this tractional element causing a traction at the optic nerve head. So, what are the problems of diabetic vitrectomy when you compare it with other vitrectomies? The vitreous in these cases are pretty tightly attached to the retina. So, inducing a PVD, relieving the vitreous from the retinal surface, they are problems. Diabetic control is not there. Cornea are usually hazy. Intraocular pressure is usually risen. There are accompanying cataracts in these patients. Intraocular hemorrhage, either intraoperatively or preoperatively, which are having active bleeders, can cause a problem of visualization. Pupils may not be dilating, and there are high incidence of PL negative postoperative. So the objective of this surgery is to remove the opacity, relieve the anteroposterior traction, relieve the tangential traction, segment or peel the epiretinal membrane, achieve effective hemostasis, treat all the breaks, and deliver laser treatment. Now, how is it done? It is done with the help of a vitrectomy machine and the latest cutters of reducing gauges now. The latest that has come right now is a 29 gauge. I don't have a picture of that. I usually prefer a 25 gauge even now. I don't usually prefer 27 gauge, not economically viable for me in my private setup. So before going into vitrectomy, we can see the three types of adhesions of the vitreous to the retina. Now, first is a focal adhesion. These focal adhesions are easier to remove with a lift and cut technique. The problem is with the second and the third adhesions, where the adhesion is diffuse, and we usually need a very meticulous dissection to relieve these tractions, and a lot of times an attempt to relieve these adhesions cause an iatrogenic break. So what are the techniques? If the induction of a PVD, which is usually very difficult because the vitreous is pegged down to the retina with the help of proliferations. So, but if in lucky cases we are able to achieve a PVD, then we remove the vitreous and we remove the blood from behind. If there are multiple adhesions that are pegging down the vitreous to the retina, then we usually do a segmentation technique where we divide these adhesions to small segments and then delaminate it. But with the current use of current sophisticated machines, what we do is just lift and cut and proceed. Wherein wherever adhesions are there, we look for a space between the retina and the proliferation or the posterior membrane. We create a gap and we go beneath that layer above the retina, and we start dissecting it. So basically, it's a lift and cut technique that we use in the latest machines that we have. Now, after we are done removing the vitreous, we need to cauterize the bleeders. These proliferations that are pegging down the vitreous to the retina are eventually fibrovascular proliferations. So these may, after removal, these may have active bleed, so which need to be cauterized with a diathermy. So this is an example of a diabetic. Am I audible?
Very much. You are audible and visible as well.
Yeah. So this is an example. So I'll be showing a few videos. This is an example of a non-resolving vitreous hemorrhage. So what we do over here is we are doing a core vitrectomy and then followed by a peripheral vitrectomy, only to see that there is a posterior hyaloid that is attached and there is a fibrovascular proliferation pegging that posterior hyaloid. So we have to free the vitreous from the central proliferation. And that's how it's done. So the central proliferation is now isolated. We go ahead with completing the peripheral vitrectomy now. Then we disperse off the bleed over the retina. Now, there is a diffuse adhesion and a diffuse traction. So we try to break these tractions into smaller segments as much as possible, so that at the end a central small bunched up traction is there, which is not causing a traction in the surrounding, and then that traction is slowly dissected off. This was the active bleeder after dissection that was there. So what we can see over here are the one second. Yeah. So what we can see over here are the white spots. These are the cauterized points of active bleed that were there after dissection of all the adhesions. So once we have cauterized those things, I mean those bleeders, we remove the bleed that is overlying the retina, and we see that there is no active bleed at that moment, and then we do an extensive laser. This was a patient having rubeosis iridis, so I have done extensive PRP in this intraoperatively. This again is a case of a non-resolving vitreous hemorrhage with a subhyaloid bleed. It's a kind of repetition, so you can see. I mean, you can run it in your head whatever I have talked in the previous surgery. It almost follows the same steps. This was a flat bleeder which continued to bleed. So in such cases, what we can do is after we clear off the bleed, we can raise the pressure of the Constellation machine or the vitrectomy machine, which gives a good tamponade for the bleed to stop, and then we can go ahead with the cautery of the like in this case. Which is followed by a fluid air exchange, wherein the fluid inside the vitreous cavity is removed and replaced with air, and then the PRP as usual is performed intraoperatively. Now, this is a case of a subhyaloid hemorrhage. So, this case has a pre-op presence of PRP marks. So in this surgery, we will see how a presence of a pre-op PRP helped in having a bloodless field. In the previous two surgeries, we saw that there were active bleeders, but in this surgery, as we will see subsequently, the bleeders are not there. So there is a large subhyaloid bleed. So basically the posterior hyaloid, the blood is trapped behind the posterior hyaloid. So we first do a core vitrectomy followed by a peripheral one. And then I'm delaminating the posterior hyaloid over here. And as I uncover that, the blood behind the posterior hyaloid, it comes in front, and I aspirate that blood, followed by a removal of the blood on the surface of the retina. Now, as we can see, it's there are no bleeders in this case, because there was a presence of a pre-op PRP, which has caused regression of all the fibrovascular proliferations to predominantly fibrotic one. And after the clearing of the vitreous hemorrhage, what I saw was, of course, the PRP was not complete. So I augmented the PRP. Now, this is a case of recalcitrant diabetic macular edema with cataract. So, after going ahead with a cataract surgery, the idea in this case was to detach the posterior hyaloid and peel off the ILM to increase the oxygen permeability and the penetrance of anti-VEGF to the macula. So, in these cases, what we do is we Yeah, so in these cases, we basically induce the PVD. There are no proliferations. So a PVD is rather reasonably and bloodlessly done. And the vitrectomy is completed. Then to peel the ILM, we have to stain the internal limiting membrane with a brilliant blue-green dye, and then remove the ILM at the macula. This case had a diabetic macular edema in which the cystic spaces had given way to form a macular hole. So an ILM stuffing was done at the macular hole because the ILM was too friable to do a inverted flap in this patient. So the hole was stuffed with the ILM and fluid air exchange was done. Now, this is a case of a vitreopapillary traction. This is a very sparsely said indication for a vitrectomy. So we can see over here, there is a severe tractional element causing traction at the optic nerve head. So what we need to do is we need to basically free up this traction from its surroundings, so the traction lies free in the vitreous cavity, not attached to any surrounding. So it is incapable of causing any traction. And of course, that traction element is also reduced to minimum possible size. So here I'm completing the vitrectomy, the peripheral vitrectomy. Then the vitreous around the traction is removed. The diffuse tractional element needs to be isolated, and then it needs to be segmented. Specifically, the traction which is causing the pathology needs to be isolated from the surrounding. That is where the traction becomes ineffective, and then the traction should be trimmed down. So this is how I am isolating that traction, whereby the tractional element on the disc is isolated from the periphery, from the surrounding, and then trimmed down to smallest possible size. This is the other end of that entire diffused tractional band. And then the fluid air exchange is performed, and of course the PRP is augmented wherever it was deficient. So these were the gross indications of vitrectomy in a diabetic patient. Now, these are of course not without complications. Complications of a diabetic vitrectomy can be elevated intraocular pressure, corneal epithelial defect, cataract formation, rubeosis and neovascular glaucoma, intraocular fibrin formation, anterior hyaloid fibrovascular proliferation, vitreous hemorrhage. One of the most common problems in a diabetic vitrectomy is incidence of rebleed. 22% in immediate postoperative period, and amongst them 13% need a repeat procedure. So how do we, what are the measures we should take to prevent it? Use of an intravitreal anti-VEGF, anti-retinal cryotherapy at the sclerotomy site, because there might be bleed that gets dissolved which are there around the port. or we may also use intravitreal gas or a longer acting tamponade like silicon oil, where we know there are a lot of bleeders, and if the tamponade goes, the bleeders will blow out. So oil can be used. Also, oil should be used when there are severe tractional components and has caused a persistent distortion. So oil can provide a prolonged tamponade, causing relative flattening of the stria that was caused by the traction. So intravitreal oil or intravitreal gas can also prevent your rebleed. Coming to the last topic of the day, there is anterior hyaloid fibrovascular proliferation. This is a very bad complication wherein there is fibrovascular proliferation just behind the lens anteriorly. It happens usually in young males with long-standing diabetes, where there is extensive retinal ischemia and florid neovascularization despite a good PRP, and is most commonly seen after phakic vitrectomies and scleral bucklings that used to be done for diabetic TRDs previously. This is one of the examples of an anterior hyaloid fibrovascular proliferation. Treatment is very, results are frustrating because, the only thing we are left with is to, do a lensectomy with anterior membrane dissection, with, VR surgery for the elevation with oil injection, but the results are not very good. So the take home message from the surgical point of view is that, if you leave the surgical cases for too long, then you will always find yourself short of crease. So you should have a proactive approach towards dealing with such surgeries, so that you can achieve a good result. What exactly the problem with following the textbooks in current scenario of advanced machines is that all the major studies for surgeries were done in the era of 20 gauges. So, wherein the results of surgeries were not anatomically and visually that superior. So the norm previously was to observe till it gets, pretty bad. But nowadays, with the advanced and sophisticated machines, wait and watch, wait and watch principle of treatment has taken a backseat, and surgeons are getting more aggressive by the day. So that is why you see in various conferences, modalities changing, protocols changing, doctors saying different stuff from what we read in the books. So, you may follow the book for your theory part, but if you're practicing, my suggestion in diabetic retinopathies would be to go pretty aggressive and operate whenever you feel like. You go with the clinical acumen, but don't wait for the TRDs to progress and involve the macula. Even if the TRD is threatening the macula, go ahead and operate it. Even if there is a vitreopapillary traction, previously they were left alone, but nowadays they are being operated. So they are changing. So in conferences, you'll be reading newer indications of vitrectomy. So this is basically a take-home message. Don't wait for the surgery in a diabetic vitrectomy as your traditional books, quote. Thank you.
Thank you, Bibhuti sir. That was really extensive and very well compiled lecture covering all the aspects from the studies to surgical management. And I think that you will have a lot of YouTube likes and it will be seen multiple times, as it covers the whole of the diabetic retinopathy as a question and for the Viva as well. So thank you
Yes,
for
no
that.
Sumit,
problem.
Sumit, I would like to take this opportunity to congratulate Dr. Bibhuti for a wonderful presentation. Dr. Kashyap, I would, for the want of the PGs who are giving Viva exams,
Yes.
maybe online, maybe
Uh-huh.
physical, could you just highlight, because it's great to know what are the newer advances, but they should, to reach that level of question answer, they have to answer first the basic questions from the examiners. So
Yes.
could you just
Yes.
give a gist of what examination findings or what are the basic principles of examination of a diabetic vitreous hemorrhage patient,
Yeah.
which is
So,
expected from a PG?
yeah. So if there is a case of a vitreous hemorrhage, and if you will not be knowing if the patient is diabetic or not. So first up, systemic history is very important. And if the patient is on insulin or on oral hypoglycemics, because the examiners would eventually ask what is the role and what is the incidence of diabetes in insulin users versus oral hypoglycemics, etc. So that history is very important. A proper vision taking is important. After these preliminary non-clinical examinations, on slit lamp examination, what we need to see for if the cornea is clear or not, that will give the first indication of how the status of the eye is. Then we need to see at the anterior chamber for the cells or for any bleed. We need to look at the iris for any neovascularization. Even if there is no neovascularization in the iris, we must go ahead with a non-dilated gonioscopy to see for any neovascularization of the angles, because even in the absence of NVI, NVA is present in at least 10 to 11% of the cases. Then we must document what grade of cataract they are having. In the examination, we must look at the posterior port. If the fundus is not visible, and if the examiners, I don't know if the examiners asked to do the ultrasound, but if the ultrasound report is there, we must need to see what is the status of the posterior vitreous detachment, what is the status of, if the vitreous membrane has formed tight enough, if there is any element of tractional detachment, if there is any, first up, if there is any evidence of detachment or not. If there is, what is the configuration, if it is a tent up or a ballooned out detachment, if there is any evidence of subretinal fluid in the ultrasound. During the history, we must also take the history of any laser being done, or any history of intravitreal anti-VEGFs. This is how I would advise the students to go ahead with the workup of a diabetic vitreous hemorrhage.
Yeah, and also very important, the other eye examination, because the students tend to miss out on that. And that gives a clue as to what is going to be the prognosis for this eye as well, if I may add.
Yeah.
There are not many questions, Kashyap sir. The one is, what is your views on the neuroprotection in the early stages of diabetic retinopathy?
Come again?
What is your view on neuroprotection in the early stages of diabetic retinopathy?
I have theory can be there, but in practice, I have never really implied neuroprotective agents to prevent, halt, or reverse your diabetic retinopathy. So till now, clinical importance is very less.
The one more basic question, like whatever Viva I have attended till now, the examiner, I have this habit of asking that what is the difference, how do you differentiate between IRMA and NVE? So just for the benefit of PGs, would you like to?
Yeah, so basically IRMA is intraretinal microvascular anomalies. So they are thin and flimsy, but not as thin as neovascularization. Also, when you look carefully, these they are present like a bridge between the vessels. So if there are two vessels, an IRMA would be between those two vessels, whereas a neovascularization would be like a tuft, or it may also cross those vessels between which they are situated. And most importantly, on angiography, that IRMA will not leak, and a neovascularization will leak.
Yeah. And Sumit, if the examiner probes you further, what else would you like to do? Then the student has to answer that I would like to do an OCT angiography if it is available. And that kind of has the newer nomenclature has divided the NVEs into 3 types, wherein it is easier to delineate which is a NVE and which is a IRMA. So that is if the examiner is probing you further. But investigation of choice remains FFA, clinical examination, and then if probe further, you can still answer OCT angiography.
Thank you, sir. There is one more question. In which cases do you prefer pre-operative anti-VEGF injection before vitrectomy surgery?
Yeah, that is a very good question, and that question was my question when I was appearing for my final exam. So basically, in my practice, I'm gonna tell you exactly what I do in my practice. So anti-VEGF is always used wherever, if there is a vitreous hemorrhage, and if I'm able to see a tractional element, if the tractional element has a lot of vascular component, and if I am predicting that dissecting these membranes are going to cause a lot of bleed, I would like to reduce the vascularity of those tractional elements. That is where I'm going to use my anti-VEGF. But what one needs to be very careful before using anti-VEGF is that the surgery needs to be done within 3 days. You wait for more than 5 days or approximately 7 days, the fibrous component starts contracting and it starts worsening the tractional detachments. So that my choice of anti-VEGF use is when I see a fibrovascular proliferation, which is very, very vascular. Secondly, I also do give anti-VEGFs, before my PRPs, and if there is a diabetic macular edema, or if I am trying to achieve a large area of PRP where I know it's going to inevitably cause an edema which is not going to resolve by itself. The third place where I use my anti-VEGF before any kind of other intervention is cataract surgery. So if there is a diabetic macular edema, and if there is cataract and I have to operate that cataract, then, and I would inject the patient 7 to 10 days before the cataract surgery, because the peak action of anti-VEGF is at 7 to 10 days, and after cataract surgery the DMEs are known to worsen. So I would inject and I would then operate on cataract at the peak time of action of anti-VEGF. So first anti-VEGF, 7 to 10 days of wait, and then cataract surgery.
Okay, sir. Thank you. And I think that answers your question, Dr. Nikita. We have covered most of the questions. So, Swapnesh, sir, anything to be added?
Nothing. I think the students should know in the today's era of anti-VEGF various properties of anti-VEGF, and that's a very common question to be asked, differentiating between Bevacizumab and Ranibizumab, and the molecular weight size, actions, which receptors do they act on. The newer anti-VEGF, they need to know at least 2-3 lines about them. So the common things have been covered very well by Dr. Kashyap, and probably they could be asked, when is the steroid the drug of choice? So Dr. Kashyap can answer that for the benefit of the students.
Yeah, I had included that in my presentation as well. Like, steroids are usually used in, so I would say, 3 indications. The first indication is a very severe diabetic macular edema, where the thickness is maybe more than 450 or 500. You can always combine a steroid with your anti-VEGF. That is where the role of steroid comes in. Another indication is a refractory DME, where anti-VEGFs are not working. Third indication is that of pregnancy, wherein we don't have much data regarding the safety of anti-VEGFs in pregnancy. Of course, some say it is safe, some say it's group D or group C of FDA, but people do usually avoid it. And first choice is laser, but if the laser is ineffective, it's not, I mean, you're not able to do the laser, then amongst injectables, steroids are the first ones to use before anti-VEGF. I mean, steroids are the choice before anti-VEGF in a pregnant lady, and that too also in second or preferably third trimester.
Yeah, I think he has answered all the possible parameters based on clinical judgment. Today we inject based on OCT. So if we see a neurosensory detachment, then below subfoveal neurosensory detachment, then steroids become an automatic choice. And also the newer concept of OCT biomarkers, the students should know a wee bit about it, that if there are hyperreflective dots seen in the intraretinal space, then that shows that diabetic macular edema or diabetic maculopathy is not only VEGF driven, but it also has an inflammatory pathway. So if there are hyperreflective dots which are seen, then steroids may be a good choice in that particular patient, maybe combined with anti-VEGF or standalone. That depends on the surgeon's choice. So I think, Sumit, we have covered most of the aspects,
Yes.
and I would request Dr. Kashyap to at least share his trial slides with us, so that our students will benefit, because I think you have covered the clinical trials beautifully, and I think the students will benefit from just revising them just before their viva, because those are the toughest questions to answer. And thank you, Sumit, for being the warhorse for this particular PG program. And I think it was well attended and well received.
Thank you, sir. Thank you, Swapnil sir. Thank you, Kashyap sir, for your lecture. And we will meet again on Thursday with the next lecture. Till then, good night.
All right. Good night, Dr. Sumit. Good night.